Um, Hi. I've seen you guys somewhere before. Um, So they told me explain health reform in half an hour, and I could do it, but I'm not. How many people have heard of health reform? How many people are concerned about healthcare reform? How many people think it will impact them positively? Interesting. How many people negatively? Wow. That's interesting. I'm going to speak specifically to exchanges and essential health benefits, but we can go anywhere you want in the law. I can't guarantee that I have an accurate answer for you, but I can provide an answer. I did not take this picture of the Capitol. Am Okay. So real quickly on insurance exchanges, and then we'll get into EHBs. Are you guys more interested in exchanges or benefits? Both, okay. Exchanges, think of exchanges as, well, the Affordable Care Act set up insurance exchanges. They're basically marketplaces, and they allow you to kind of shop for benefits, various levels of coverage. So think of it as kind of like a strip mall, okay? The exchange is kind of the mall. You go into the mall, you decide which store you want to go to. Maybe you want to go to Safeway because you're looking to save some money on groceries. Do you guys know what Safeway is? Yeah. And or maybe you really care about quality and you want like the platinum level, so you want to go to Whole Foods and get the organic stuff that my wife likes, but I don't. And so the exchanges will be that strip mall that will allow you to kind of go in and purchase a plan based on the needs of your family. And so some estimate that there will be about 24 million individuals who will purchase their coverage this way starting January 1st next year. These exchanges are supposed to be up and running and allow that choice by October of this year. If you've looked at your calendar, that's how many months away? We are just now getting final rules released that relate to the products that are supposed to be offered on those exchanges. And so we are under a very tight timeline to ensure that everything is kind of up and functioning and working together. I can tell you, when I worked on Part D on the Hill, we had a 2 to 3 year lead time in setting up that benefit in the Medicare program. So it was an existing program. We're adding a benefit to it. Yes, we were doing things a little bit differently, but there were still bumps in the road. So I think we can expect bumps in the road related to the exchanges. And it's not just related to what might be offered on the exchanges, but how the states are kind of looking at presenting the products. So 18 states have decided that they will run their own exchange. Okay, so California probably being the biggest, New York is up there. And if you think about an electoral map, you can see the states on the left coast and the right coast, and that's not a pejorative. And the states kind of, Minnesota at least, or in the Rust Belt area, are deciding to either go and set up their own exchanges or partner with the federal government. And then kind of the red states on the electoral map are all kind of saying, you know what, feds, your law, we'll leave it up to you. You figure it out. And this is going to mean very different things to different people, because if you live in Texas, you will have a very different experience than if you live, for example, in Washington or Oregon. And you'll have a very different set of experiences in Washington than you will in Oregon, because the states have a lot of flexibility to set up the exchanges and determine how products are offered and what products, in fact, are even offered on the exchanges. And you don't need to worry about writing all this down. I think we'll make the slides available. Yeah. So sorry, that was my next point on the next slide. Again, they're going to vary a lot based on what the states decide to do, and they'll vary a lot based on what the feds decide to do. So if the federal government makes a decision that says only products with this type of network adequacy requirements are allowed on the federal exchange, that might be different than a more robust coverage option offered at a state-based exchange. Okay, are we getting it? Variation will be significant. So again, 23 million workers. Individuals with incomes up to 400% of poverty will receive a federal subsidy payment. It kind of phases down the higher you go up on the income scale. Sorry, someone was motioning to me back there. And the subsidies will be somewhat generous, particularly at the low end, but they may not provide a 100% subsidy even at the low end. So some insurers recently have been talking about some of the mandates that are required for the coverage, particularly age rating, which says that if you're younger person, you're going to pay a little more. If you're older, you're going to pay a little less. Well, that younger person may actually end up paying more in premiums than if the ACA was never enacted. And so that raises a question as to whether people will actually sign up for the program. And if you know about this generation, they're making decisions about buying cars and buying houses, putting things off to a large extent. So it's something that people are concerned about. We have to keep an eye on. And then the last thing I would say is, are there any folks who know someone or is enrolled in a high-risk pool? So huge source of coverage. It's a recognition that people need that type of coverage. Those pools are going to be phased out, is my opinion. The federal one stopped accepting new enrollees a couple weeks ago. The state ones are basically, every incentive at the state level is to stop doing the state high-risk pools and put people into the exchanges. Now, the effect of this is that you're going to have some pretty high-cost people entering into the exchanges. That could raise the average premium rate and make things a little more expensive. But those things you will have to transition, probably starting in January. So, questions on exchanges. What does it look like? I don't know. Most people think it's going to look like a kayak.com or Orbitz, something like that. Seriously. They have all kinds of interesting names. One's called the Kiwi Exchange. One's called, California was thinking about avocado. I don't know. But if anyone's ever been to eHealth Insurance, go to ehealthinsurance.com and you could probably get a good idea of what this looks like. You'll enter your zip code, you'll enter some demographic factors, and it'll bring up about 10 different options. If you want more, you can search for more. But what you buy on those exchanges is going to be fairly standardized, we think. The final rule for what a health plan has to offer just came out last Friday. Is it Friday? Thursday. And it's called the Essential Health Benefits. And basically the law says you've got to cover as a health plan these 10 different benefit categories in order to ensure that people are getting value for the insurance they purchase, right? And so it's everything from hospitalization to physicians to prescription drugs to rehabilitative care and habilitative care. Has anyone ever accessed habilitative care? Yeah, I don't know what it means either. If rehabilitative is to get back, habilitative means to live, I don't know. Anyway, they're going to try and define it, and there are actually some special rules around habilitative care. I don't mean to make fun of habilitative care. And for those benefit categories, the cost sharing can't exceed statutory limits, with the one exception of small group deductibles. So basically what happens is each state will select a benchmark plan, okay? Think of this as something that's already in the market because the law says you have to provide something that's typical of an employer plan. And so you basically have four options. It's the largest plan by enrollment in the small group market. So what a small business might purchase in the small group market, the largest one. They wanted to get that typical concept of a typical employer in there. And then they said, well, what about the state employees? They get a pretty good deal. Let's give them what the state employees may have. And so the state could choose that as a benchmark. The third is the FEHB, which members of Congress get. And the fourth is the largest commercial non-Medicaid HMO in the state. And so if you look through the list of the states, they've all kind of chosen different things, Most of them have chosen the first option, the typical employer plan. And one thing that's in the law, but also the regulation, is that you've got your benchmark plan, and so it kind of looks like what's available in the marketplace. If you go to a state legislator or go to a governor's office and you say, I've got this specific condition, for example, and we only have this special service that we need, and we're kind of unique in the marketplace, and we'd like to add this to the list of benefits that are covered in plans offered on the exchange, the state is probably going to turn you down. Let me repeat that. The state is probably going to turn you down. Yes. The reason is that the law specifically says that any new benefit mandate added after a date certain will have to be picked up by the state. The state has to proactively pay for it. So I can tell you in this budget environment, it's going to be a tough sell. Before, the benefit mandate was kind of picked up by the insurers, and they said, you have to cover this, and the insurer said, okay, I'll pass it through on the premium side. The state is going to have to pay for this, so it's going to make our job a little bit harder to the extent that that happens.
Explain that a little better. I'm sorry, or a little more.
Sure. So the law says if I'm a state and let's do chiropractic care. If I'm a state, in the past, what I said was every health plan that I have authority over in my state has to cover chiropractic care, okay? Blue Cross Blue Shield and United and Aetna and all these other plans had to cover it, right? So how did they pay for it? Well, they probably increased their premium by 20 cents per person and pass it on to every consumer, right? To pay for it. Now, under the Affordable Care Act, it says if the state enacts that requirement, every plan in the exchange has to offer chiropractic care. The state has to pay for it. Okay? So when you go and you talk to your legislator at the local level and you say, I'm having a hard time with this, I need access to chiropractic care because of my condition, okay? The legislator's going to turn around to you and go, how do I pay for it? Because they're facing the same kind of budget issues that we're facing here nationally. So just real quickly, let's basically, plans can offer proxies to the benchmark. They can substitute benefits in, but it has to be actuarially equivalent to the benefits they're replacing. So I don't think this is a big deal. We'll get to the prescription drug issue in a second. Importantly, plans cannot be considered as offering essential health benefits. Therefore, they can't sell their product on the exchange if they discriminate or use the benefit design in a way to discriminate against specific populations or based on age, medical dependency, quality of life, health conditions, et cetera. Basically, I can't make my benefit in a way that says people who have a hard time climbing stairs are not going to sign up for my health plan because I'm not going to have an elevator in my doctor's offices. Everyone's got to climb up the stairs to get to see my doctors, right? You can't discriminate based on some of those conditions. Cost sharing, this is directly tied to the law. There were limits on cost sharing. They're basically matched to health savings accounts. So when you hit that out-of-pocket limit, you stop paying. It does not apply to services obtained out of network. Let me repeat that. The cost sharing limit does not apply to services obtained out of network. Well, pre-existing conditions are covered, but if you're going out of network, still gets reimbursed, right? It does not count, though, to your cost limit. So if you're seeing everyone in network, if you basically spend $12,000 and change, 100% of your costs are going to be picked up at some point, okay? If all of your coverage is through out of network, you never hit that 12,000. You never hit that 12,000. These essential health benefits apply to individual and small group inside and outside exchanges. And you can only get the subsidies inside the exchanges. So this category that you're talking about, preventive and wellness services and chronic disease management, will be, the out-of-network. So you have that benefit covered in your plan, right? The preventive and the chronic management and all that stuff will be a part of your in-network services, and they will provide coverage for out-of-network services. The difference is if you get the benefit in-network, at some point you will be not exposed to any more cost sharing, right? You'll be protected against those costs. If you're out-of-network, like most rare patients are, you will be exposed. There's another federal rule here. It's hard to keep track of all the federal rules, but there is a rule around network adequacy. And so the Affordable Care Act also said that there are rules, plans have to offer an adequate network of services in network, okay? Now, my concern is that the combination of this cost-sharing provision and the in-network requirement may not be sufficient to ensure people have access to all the care they need, right, at an affordable rate. So it's something that's going to play out within each exchange, I think. And, you know, one of the comments was, will people be SOL? I don't think we know yet. But it's a little disturbing because we're only, how many months away from October? I can tell you that the insurers are still trying to, one, figure out what all this means in terms of putting packages together, two, figure out how to price those packages to try and offer them on exchanges, and then three, figure out, will I know who's eligible for subsidies, who's not, who's in Medicaid, who's not, right? All those things have to be kind of resolved in the next 6 months. Yeah. And by the way, I'm not a lawyer, so none of this is free.
How does the Affordable Care Act affect self-insured employers? My husband works for Dell and is self-insured.
Yeah, largely they're exempt. There are some there are some basically for purposes of this, I would just say the general issue is this applies to individual and small group market. So a Dell, or not a Dell, a company like Dell, generally not impacted by any of this stuff. Yeah, we're seeing a lot of so there are a lot of taxes that help pay for the Affordable Care Act that are getting built into 2013 rates, especially, yeah. And we're hearing, I mean, some of the data that we're seeing come out of Milliman and some other surveys are that rates could go up by as much as 200% in some markets. No, guys, really, I don't want to scare you. This is seriously a very complicated issue, and there's a lot of variables still right now, and so we're kind of in this gray area where we don't know how all this is going to play out, and there's a few more rules that still need to come out, like the premium rating rules, the reinsurance risk adjustment risk corridors. So, and this final rule on essential health benefits just came out on Thursday or Friday. So I don't want to scare anyone here. I do think that in general, you are going to get more for the coverage, but you're also probably going to pay more. Real quickly, I know a lot of people, access to drugs and drugs that are covered are very important. So in the final rule, basically plans have to cover at least one drug in every category and class of the USP. Now, one of the problems with the USP is that it doesn't always pick up a lot of the rare products. The second thing is that, or the same number of drugs in the EHB benchmark, whichever is greater. So it could be one drug per category class, it could be 50. And HHS in the proposed rule basically says that there's robust coverage. They expect this would only hit a couple of classes in terms of providing some additional coverage. One of the problems is that a lot of patient advocates, patient groups said, why don't you just make it like Medicare Part D? You cover all or substantially all of each drug in each category and class. Well, HHS didn't adopt that approach. I think they were concerned about cost. I don't want to get inside their head. I don't know what they were concerned about. But Another outstanding issue is HHS says that if the drug isn't covered in the category or class, then the covered individual, the patient, has to have some process to get access to it. So think internal, external appeal, external review, something like that. They're not clear in the rule. They say they're going to delineate that in sub-regulatory guidance in the future. Future's kind of now, right? We need to have these products up and running in October. So I guess we'll figure out what that looks like. Another, I think, concern is about utilization management. And one of the things, just to let you know, that was done in the rule said that plans, they added a rule of construction that basically said nothing should be construed as precluding plans from using utilization management. I think what HHS was trying to get at was some of the more care coordination techniques to say, look, we want people to do more of the good stuff and less of the bad stuff. And so we put this rule of construction in there. They also repealed the prohibition on discriminatory cost sharing. HHS did. It's not something that's been talked about yet. I'm trying to get a little more clarity around what the impact might be. I think what they were trying to get at is value-based insurance design, and saying that we will charge a higher copayment, for example, for lower back pain MRI, right, which you don't want to do. You want to kind of treat that progressively. Versus a $0 copay on, for example, an out-of-network visit for someone with a very rare condition. But they did eliminate that, and there was very little discussion in the rule about what that was and the implications were, other than related to cost. But I think they were trying to get at, incentivizing the good things and disincentivizing the bad things. Sorry. I said I could explain the ACA in half an hour. I feel like I've done a lousy job. We will do a webinar. I'll be available today, tomorrow. If I can't answer your questions, we'll definitely do the research and get back to you on it. But this is very important, guys. This is like a sea change going on in the marketplace right now. And I think, we'll just continue to be a resource for you, myself, Jen, Jim, Julia, obviously. However we can help out, just let us know. And thanks again for all that you're doing.